celebrating World Asthma Day, I'm going to invite Dr. Gifton to as our speaker today.
Hello, good morning. Welcome to I think it's our second Asthma Day where we're taking over a grand round. I wanted to welcome our speaker, Ann Kelsey Lamb, who is coming to us from RAMP, which is the Regional Asthma Management and Prevention Initiative, where she's the director. She did her undergrad at Bowdoin, and she did her MPH at the University of Michigan at Ann Arbor. And she's going to come talk to us about what we can do to collaborate and reduce the burden of asthma in our community. Thanks so much for coming.
Thank you. Good morning. It's an honor to be here. To start, I have nothing to disclose. All right, so as Dr. Gibb mentioned, I am the director of RAMP, and we are a project of the Public Health Institute, which has been in existence since 1996. And our mission is to reduce the burden of asthma through a broad and comprehensive approach. We don't provide direct service to patients and families, but we support those who do with tools, technical assistance, and capacity building. We also serve as a convener, bringing people together to advocate for policy and systems change. We are particularly concerned about the asthma disparities that we see based on race, ethnicity, and socioeconomic status. And we focus a lot of our work on the social and environmental inequities that we see contributing to those disparities. So there are 4 objectives for today's presentation, as listed there. And I'm going to start with the first of just briefly reviewing some data. So as you are all aware, since you chose to come this morning, asthma is a very prevalent public health issue. Over 25 million people have been diagnosed with asthma nationwide, and over a fifth of those people live here in California. It is the leading cause of school absences due to chronic disease and a common cause of pediatric emergency department visits. I understand that most of you treat patients who are from either Alameda County or Contra Costa County, so we're going to look at some county level data as compared to statewide. So this is asthma prevalence for children ages 0 to 17 based on the California Health Interview Survey. Now I should note that the Contra Costa data is considered unstable because the survey sample size was not large enough. Nevertheless, I think what we can see here is the prevalence is higher in these 2 counties than statewide. So now we're looking at OSHPD data, first at hospitalizations and then at emergency department visits. And as you can see, again, it's higher for Alameda and Contra Costa counties than California. This is hospitalizations, and this is emergency department visits. So I think the take-home message from these slides is that by serving children in Alameda and Contra Costa counties, you are seeing higher asthma prevalence, higher hospitalization and emergency department rates than if you worked elsewhere in the state. And so it's really important to be talking about why we have these high rates here and how we and others in the community can support you as clinicians in addressing this issue. All right, so now let's take a look within each county. This is for all ages in order to have large enough N. But if we break down ED visits by race, we see significant disparities. And I think the thing that probably jumps out at you most here is the red line. And this is ED visits for African Americans in Alameda County. And it is about 4 times higher than for any other racial or ethnic group. Now, if we switch to Contra Costa County, you're going to think you're looking at the same slide because it really mirrors the great disparities that we saw in Alameda County. So is there any good news in looking at data? Well, the CDC came out with this report in February of this year and reported that nationwide, hospitalizations have been steadily decreasing, and they've decreased by 50% since 2003. In addition, the rates of missed school days has been declining as well. Nevertheless, 1 in 6 children with asthma visits the emergency department annually, and the disease disparities are significant and not decreasing. So what do we make of all of this data? We have made progress, and we clearly know a lot about what works. but we have more work ahead of us, and I think really focusing on those disparities is something that we all need to prioritize. Which brings me to the second objective of this presentation. I'm going to talk a little bit about some of the social determinants of health that we know impact asthma that we're seeing among children in this community that you're serving. So first of all, does anyone want to offer a definition of what are social determinants of health? Haven't had your coffee yet this morning?
Income.
Income is a great example. Environment, absolutely. Education, yes, indeed. So I like to use the World Health Organization definition, which is the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces: economics, social policies, and politics. And indeed, these factors do have a significant impact on health. So this is one of many versions of this kind of graph that I have seen, and the exact percentages differ and the exact terms they use differ, but the point here is that if you look at, let's see, the social and economic factors, physical environments, and health behaviors collectively having much greater impact on population health than genes and biology and clinical care. So it's something we need to pay attention to. So how does this relate to asthma? Many of you already started to answer this in defining what are social determinants of health. We have indoor environments, and this is a picture of a very typical school ceiling with mold or at least water intrusion on the ceiling panels. Outdoor environment, this is right here in Contra Costa County, and this one right here in Alameda County. And then home environments, where we see substandard housing conditions, we see problems with pest infestations, and other things that we know have a direct impact on asthma. So we put together a framework for reducing the burden of asthma that demonstrates the role of these social determinants of health. And we adapted this from a framework created by BARHI, the Bay Area Regional Health Inequities Initiative, and we made it asthma specific. So if we start with the disease box, there we have asthma. And to the right of it, we know that there are differences in outcomes: mortality, morbidity, other impacts like family functioning, missed work and school. And that's probably where most of you are intervening. And we know that if we intervene well, we can improve what those outcomes are. And then we know that with asthma, genetics plays a role. But since I'm in public health and not health, I'm going to ignore that for now and focus on these boxes to the left. So immediately to the left of the disease, we have risks. And this includes risk factors like exposure to environmental triggers in homes, schools, and outdoor air environments. And it includes risk behaviors like smoking. To the left of that, we have the daily living conditions. And here's where we see the environmental and social inequities that are determining which people or which groups of people are more likely to face these risks. So here we have things like the inequitable distribution of air pollution, residential segregation, and the inequitable access to healthy housing. And of course, these inequities aren't happenstance, but rather a result of political and institutional power, which, at least in our country, are shaped by larger social inequalities around race, ethnicity, immigration status, gender, and socioeconomic status. So it's these boxes to the left of the disease that represent the social determinants of health, and I'm going to choose a few of those social determinants to go in a bit more depth. So starting with the risk box, we're going to look at the risk factor of exposure to environmental asthma triggers. So this is likely an aspect of asthma that you're all extremely familiar with. When we talk about environmental asthma triggers, we tend to divide them into two categories: allergens listed here and irritants listed here. The evidence connecting particular allergens and irritants to asthma exacerbations was well established when I started this work 16 years ago. But during that time, the evidence has grown and started to point to some of these triggers actually causing the onset of asthma in otherwise healthy people. So this URL at the bottom of the slide will take you to a trigger table that we created and is posted on our website that summarizes and cites the relevant literature linking each of these irritants and allergens to asthma. And I will share these slides, so you don't need to quickly scribble that down. Okay, I'm going to skip over exposure to asthmagens because that's primarily a concept that we talk about in the context of occupational health. And you're presumably treating a pediatric population, so less relevant. But I think the point I want to make about that is just this idea that the causation link is becoming stronger as research develops. So what I'm going to focus on next is exposure to stress. And I'm going to start with talking about 3 different kinds of stress, because stress isn't always bad. There's a positive stress response, which is a normal and essential part of healthy development. It's characterized by things like brief increases in heart rate and mild elevations in hormone levels. So some situations that might trigger a positive stress response are things like the first day at a new school with a new caregiver, or getting an injected immunization, or for adults, getting up to speak in front of a room full of people. This is the positive stress response. Then there's tolerable stress response. So this activates the body's alert systems to a greater degree as a result of a more severe or longer lasting difficulty. So this might include things like loss of a loved one, a natural disaster, or a frightening injury. So if the activation is time limited and buffered by social support, the brain and other organs recover from what might otherwise be damaging effects. Which brings us to the toxic stress response. So this can occur when a child experiences strong, frequent, or prolonged adversity. So this includes things like physical and emotional abuse, chronic neglect, caregiver mental illness or substance abuse, exposure to violence, or even the accumulated burdens of family economic hardship. So this kind of prolonged activation of the stress response systems can disrupt the development of the brain architecture and other organs and increase the risk of stress-related diseases and cognitive development well into the adult years. So as we talk about the impact of stress in children on health, there's been a lot of recent research and talk in the field about the concept of ACEs, Adverse Childhood Experiences. So there was a questionnaire that lists 10 types of childhood trauma divided into 2 categories, 5 personal types of trauma and 5 family types of trauma. So in this questionnaire, if someone has experienced a certain type of trauma on this list, they get 1 point. And at the end of the questionnaire, they have an ACE score that ranges from 0 to 10. And high ACE scores are associated with a number of health issues, even into adult life, including heart disease, cancer, and diabetes. So this shows some research looking at the relationship between the ACE score and asthma. And it shows that an increased number of ACE exposures was indeed associated with an increased odds of asthma. So while the ACEs research is extremely important in thinking about how we are supporting children with healthy development, we know that there are some stressors that are not included in the ACE questionnaire that are very relevant to children's health. And one is racial discrimination. So researchers at UCSF have led some groundbreaking work in this area. Dr. Neetha Thakur presented on some research in 2017 showing that African Americans who reported that they had experienced racial discrimination have a 78% greater odds of having asthma and 97% greater odds of having poorly controlled asthma. And in this research, they found a dose-response relationship. So for African Americans who reported experiencing discrimination often, the rates were higher than those who had experienced it, but rarely. And they were about 2.5 times higher than people who never experienced discrimination. Another stressor that people have been studying quite a bit lately is exposure to community violence. And so I'm just going to briefly touch upon 3 studies. In a population-based case control study of asthma in Puerto Rico, children who had heard a gunshot more than once and were afraid to leave their home because of violence had 3 times the odds of having asthma as those who had heard gunshots not more than once and were not afraid to leave their homes. In New York, parental reports of not feeling safe from crime and not feeling safe walking in their neighborhoods was associated with nearly twice the odds of their children having asthma. And a study in Chicago found that children exposed to medium or high levels of community violence were 55 to 57% more likely to have asthma. So the degree of the risk varies across studies, and the way that they define exposure to violence differs across studies. But collectively, this body of research is really starting to suggest that exposure to violence in childhood increases the risks of asthma. Okay, so let's move to the box to the left, to the daily living conditions. So these are the environmental and social inequities that determine who is more likely to face these risks. So we're going to start with air quality, and I'm grouping in with that land use and transportation. So it's well established that certain components of outdoor air pollution not only exacerbate asthma, but can lead to the onset of asthma in otherwise healthy people. The issue I want to discuss as part of this presentation with regard to air quality as a social determinant of health is that some communities are disproportionately burdened by air pollution. And it's not by choice. Historically, zoning ordinances have effectively maximized property values of the wealthy while simultaneously relegating low-income and people of color to areas zoned for industrial use. And further, redlining policies have prevented people of color from buying homes in certain areas, institutionalizing segregation, and preventing the accumulation of wealth in some cases. So when we talk about air pollution, we talk about it in terms of 3 sources, and I'm going to talk about the first 2. Mobile sources, such as cars, trucks, trains, and ships, and stationary sources, such as factories. So in thinking about mobile sources, we focus a lot on freeway, proximity to freeway, because that's where a lot of the mobile source pollution is. And in Alameda County, the proportion of African Americans and Latinos living within 500 feet of freeways is higher than those living beyond 500 feet. And that's really important because that's where the pollution is. And in fact, in 2003, the state passed legislation prohibiting any new schools from being built within 500 feet of a freeway because it's not safe. And yet, we have certain populations disproportionately living there. When we think about freeway pollution, we're particularly concerned about diesel exhaust when we're talking about asthma. And the Alameda County Department of Public Health did a report on community vulnerability to freight transportation. So the freight transportation system is basically the diesel trucks moving up and down the freeways and in and out of the Port of Oakland to transport goods. And this map that the county developed as part of this report shows vulnerability to freight by census tract. So the darkest red is the highest vulnerability, and the lightest colors are the lowest vulnerability. And so when we look at this map, we can see that a lot of the red is running along a particular freeway. Does anyone live in the area and know which freeway this is? Okay, so 880. And it's not the same for 580. And the reason is that there is a policy prohibiting diesel trucks from going along 580 through Oakland. And so all of those trucks are on 880 instead. And as you might expect, air pollution is higher along 880. So concentrations of black carbon are roughly 80% higher along 880 than 580. Of nitrogen dioxide is 60% higher, and the concentrations of nitric oxide were more than double. So you would expect that. Looking at the demographics, people living in close proximity to 880 are disproportionately low-income communities and communities of color. And people living along 580 are disproportionately of a higher income level and disproportionately white. So this was a policy decision that impacts asthma. And here's how it impacts asthma. So this was also part of the county's report, where they did a comparison of asthma emergency department visits for census tracts that were most vulnerable to freight compared to least vulnerable. And so as you can see, the darkest red, asthma ED visits were 3.5 times higher than for the lightest color. Okay, so now we're going to turn to air pollution from stationary sources. So this shows which racial groups live closest to toxic air release facilities in Alameda County. So the furthest left column is people who live within a mile. The middle is people who live between 1 mile and 2.5 miles. And the right is people who live greater than 2.5 miles away. And then the different color bars represent different racial and ethnic groups. So if we start at the top with Latinos, we see a greater proportion living within 1 mile, and then it decreases as you get further away from the toxic air source. The same is true for African Americans, represented by the light pink. The opposite is true for whites. So that was for Alameda County, and now I want to turn a bit of attention to Contra Costa County, because there we have some pretty impressive stationary sources of air pollution through the refineries. And the communities of Richmond, Martinez, and Benicia all experience a lot of air pollution from these refineries. So according to the California Department of Public Health, in 2009, there were 123 asthma ED visits per 10,000 residents in the Richmond zip code that houses Chevron, compared to 48 for the state as a whole. And if we look at who lives in that zip code, it's 40% Latino and 23% African American. Now, I want to go back to when we were talking about stress and the stress of discrimination. So a UCF staff researcher, Dr. Ahn, has done some amazing research showing that the combined effect of exposure to air pollution and experiencing racial discrimination is greater than you would expect by just adding those two risks together. So for people who experienced discrimination and had high nitrogen dioxide exposure, they were 3.5 times more likely to get asthma. Okay, now we're going to talk a bit about housing. So we all know that housing is very closely linked to health and very closely linked to asthma. So when we talk with families affected by asthma about their housing, there are a lot of things that we can educate them to change. So don't allow smoking in the house, don't allow the pets to sleep in the kids' bedroom, put on the dust mite covers on the mattress and pillows. But often there are factors resulting from substandard housing conditions. So we're talking about things like mold and pest infestations. And in places like Oakland, where 59% of residents are renters and 30% of housing is considered substandard, this is something to really pay attention to in the patients that you're seeing. So this graph shows that low-income people and people of color are more likely to face substandard housing conditions. So these top 3 lines, the squares represent low income, the maroon is African American, and the green is Hispanic. So this is from a report that PolicyLink just released, looking at the housing situation in the Bay Area. I'm assuming that most of you live here and you have recognized that rents have been going up lately. And according to their report, between 2000 and 2016, rents increased by 24%, while renter incomes increased by just 9%. And 6 of every 10 economically insecure residents are renters, and 75% of them are paying too much for housing. So economists have said that we should not be paying more than 30% of our income on housing. And, right, and some giggles here. There's a term, if you're paying more than 30%, that is called rent burden. Okay, so this looks at rent burden for different racial and ethnic groups in the Bay Area. The gray dots are the percentage that were experiencing rent burden in 2000, and the orange dots are those that are experiencing rent burden in 2015. So it may not be a surprise that for every group it increased. And it may also not be a surprise who the highest groups are: Latino and African American and Native American as well. But I think the thing that's most noteworthy when I look at this is the size of the increase. So the size of the increase is greater for communities of color. And we don't see this slowing down right now when we look at the housing situation here. So this is a concern. All right, so how does this relate to asthma? If people can't afford safe and healthy housing, they will have to settle for unhealthy housing. And really, a lot of residents are too fearful to complain to their landlords or to call code enforcement. And this problem is exacerbated for undocumented residents who are living in this new culture of fear that has been created and far too afraid to complain. And as you can imagine, there's a lot of stress related with all of this, and we already talked about the impact of stress on asthma. Okay, so returning to the framework, hopefully some of my examples when discussing the daily living conditions gave you a sense of how the political capital and power and institutional power are creating these daily living experiences, as well as how they are associated with social inequalities. So, I mean, basically in sum, there are policy decisions that result in where industries are located, which freeways allow diesel trucks, who can receive loans to purchase property, as well as a history in our country that made it harder for some groups to accumulate the wealth that helps them live in healthy and safe housing and communities. So, are you feeling overwhelmed? Hopefully, okay, a couple nods. I was going to say hopefully not, because that's not the intent. The intent is just to take a moment as clinicians to see beyond the role that you have. And I'm not asking you in this presentation to change your role, but rather to be aware of these other dynamics so that you can screen patients and connect them with people that are addressing these social determinants of health. So I shrunk down the blue boxes, the light blue boxes here, to just list the title. And I added purple boxes, which are the kinds of interventions that we can conduct to intervene at each of these levels. So I would imagine that most of you spend most of your time in this far right box. So for people with asthma, we can improve their outcomes if we're providing quality clinical care and support for self-management. And that is undoubtedly necessary. It's essential and extremely important. Some of you may also be working in this box, providing health education, either doing case management or referring to your colleagues for case management. You might also refer to trigger reduction interventions like Asthma Start, which we'll talk more about in a couple minutes. And then further to the left is where we're working and where a lot of our partners and the community asthma coalitions are working. And that is the community level advocacy and the larger scale policy and systems change. So that's what I'm going to talk about next, bringing us to the third objective of this presentation, is to describe some of the available community resources that can help practices with their asthma care by starting to address some of these social determinants of health. And we're going to start with housing. So asthma home visiting programs are a gold standard intervention. The Community Preventive Services Task Force recommends it for people with poorly controlled asthma. And in these home visits, a community health worker, social worker, or other qualified professional will go into the homes of families affected by asthma. They will provide education about asthma management, generally reinforcing messages that were delivered by the clinicians in the office setting. And they will also do a home environmental assessment to identify asthma triggers and work with the family on ways to reduce exposure to those triggers. So we're very lucky to have one of the first and best asthma home visiting programs in the country, right here in Alameda County. And that is Asthma Start, which is run by the Alameda County Department of Public Health. They provide home visits free of charge to anyone who lives in Alameda County, is between the ages of 0 and 18, has been diagnosed with asthma. Now for your patients in Contra Costa County, it's a little trickier. When I started at RAMP, there was a very robust home visiting program associated with their public health department. And they lost funding and didn't continue the program. Both Lifelong and La Clinica have had small grants to provide a small number of home visits in particular communities within Contra Costa County, but both of those are coming to an end this summer. The Contra Costa Health Plan is starting a program, so that is good news, but it is not up and running yet, so we can't give you particular information about referring. And that brings us to one of the challenges that we're seeing, which is that often these asthma home visiting programs rely upon grant funding, which means they kind of come and go and they're hard to sustain. Now in Alameda County, the Alameda Alliance for Health, the county's Medi-Cal managed care organization, does pay for their beneficiaries to receive services from Asthma Start, which is great, and we hope that they will serve as a model for other MCOs throughout the state. But in the meantime, we have also been working on a state-level policy. And in partnership with Children Now and the California Pan-Ethnic Health Network, along with a broad group called the California Asthma Financing Work Group, we have been advocating for Medi-Cal reimbursement for community health workers and other qualified non-licensed professionals to receive reimbursement for providing asthma home visits, so long as they are referred by a licensed clinician. We're getting close. We think we're almost there, and look forward to that happening, fingers crossed. So this is a picture of us. We had legislation last year authored by Assemblymember David Chu, and this is him, along with a family who received home visiting services from the San Francisco General's program, and they provided testimony, and then the rest of us are advocates here. And the bill passed through every vote with bipartisan, near unanimous support, and then the governor vetoed it. And the reason he vetoed it is because he said that it can be done by the department through administrative action. Well, it was the department who told us to get legislation to give them the authority to do it. So we've kind of been going around in circles, but we are now working on the budget process, and the Senate Health Committee just voted in a line item for the budget to cover these. And if the budget gets included, then that serves as a mandate for the department to make this change. So fingers crossed. But despite the enormous success of asthma home visiting programs, we kept hearing from the asthma home visitors that yes, they can work with families on making some changes to their home environment, but there are those factors like mold, like pest infestations, that renters often can't do anything about. So in 2009, we formed the California Healthy Housing Coalition, and this group has successfully led a number of state policy changes to hold landlords accountable for providing safe and healthy housing. So we had a number of bills related to pest infestations, promoting the concept of integrated pest management, which is a long-term prevention-oriented solution to pest infestations that reduces or eliminates the use of harmful pesticides. We also passed a bill making mold out of officially a substandard housing condition, which made California the first state in the country to do that, which is kind of amazing. So here we are receiving an award from HUD for this policy work. Okay, so this is all interesting, but what is the role of a provider, you may wonder. So you can correct me if I'm wrong, but I think that often providers don't ask their patients about factors that feel outside of your control. But we really encourage ask. Ask about the home environment, what is triggering their asthma, and then refer them. So probably you're already asking if someone smokes in the home, and then if they are, you're connecting them with a quit line or some other cessation support services. And if you're not, please do. But you can also now ask them, do they have mold? Do they have pests? And if so, refer them to programs like Asthma Start or to legal aid organizations. So in terms of referring, this is the referral form for Asthma Start. And I have this up here, not for you to read, but just to see that it's rather simple. And there's this URL where you can find them, but we also have the director of the Asthma Start program with us today, and they have a table outside so you can talk with her about referrals as well. And this is an example of a housing resource guide that we developed. We developed one for each county, and it's relevant contact numbers related to housing, so legal aid, code enforcement, etc. and those are available on our website. So in terms of what is the role of the provider, certainly ask and refer. There's also the opportunity to advocate. And we do a lot of advocacy, and I can tell you that when a clinician provides testimony, the policymakers listen differently. And they really value the input of clinicians. So clinicians don't have to be involved in the coalition to plan the advocacy, to write the bill language, to meet with committee staff. You can let us as advocates do that, but if you make yourself available for us to call upon for those key hearings so you can provide testimony, it makes a world of difference. Okay, so moving to outdoor air quality and what's going on there. We have long been part of a group called the Ditching Dirty Diesel Collaborative, which brings together environmental justice and public health groups around the Bay Area to try to address the disproportionate burden of diesel pollution on low-income communities of color in the Bay Area. So we have done things ranging from educating truck drivers about the health impacts of idling to advocating at the state level for better regulations around diesel trucks, to mobilizing residents to understand their rights and be able to speak up for their health. And with this, again, the role for clinicians can be to advocate. This is someone providing testimony at a land use and transportation hearing. And again, just being able to get up there and say, I know that the outdoor air pollution in the communities in which my patients live is hurting their health. Makes a big difference. Okay, so the last environment I'm going to talk about is schools. We know children spend much of their day at schools, and the environment there is really important. We have been doing a project with school-based health centers because we knew that research showed that school-based health centers were already having improved asthma outcomes. So we knew they were effective in clinical management, and we wanted to support them in also addressing environmental factors because of their unique connection to the school and the community and the family. So with a grant from the EPA, we've been working for the past 3 years with school-based health centers who have been implementing interventions. The Breathmobile is another really important school-based intervention, and it is run by a former Children's Hospital nurse